Okay, so next set of questions.
A 52-year-old man presents to the emergency department after several episodes of vomiting over the past 12 hours. He now complains of sharp worsening chest pain and he has vomited blood once. His vital signs show blood pressure of 90/60 and a heart rate of 110. An upper endoscopy is scheduled. What is the most appropriate initial management step? A. Administer IV ondansetron and observe. B. Start high-dose oral PPI therapy. C. Start high-dose intravenous PPI therapy. D. Schedule immediate endoscopy therapy. E. Perform transarterial embolization.
Okay.
Hmm.
So, Doc, which one will you go for?
I'm stuck between A and C.
A and C. Administer IV ondansetron and observe. IV ondansetron, what is it going to do?
An antiemetic, and they said that he keeps vomiting for the past 12 hours, right?
Okay. So B says high dose oral PPI. C says start high dose IV therapy. So you said you are torn between A and C, right?
Yes.
Looks like some people
But then
also
the A is throwing me off because you can't observe the person is hemodynamically unstable. So I don't think
okay. So now
so.
you know you are using one principle of elimination, right?
Yeah, C.
So
Exactly. They already
the correct
scheduled
answer is
A.
C, right? IV
Yeah.
proton pumping, IV PPI therapy is the most appropriate initial management step for patients with active upper GI bleed. You know, this helps stabilize the clot and reduce further bleeding before endoscopy. Remember, this is totally different from the other one we did where the patient had a bleed. They did endoscopy, the bleeding is no more. And it was obvious that it was a malarialized state. Usually, if you are in rural Alberta, rural Nova Scotia, rural Saskatchewan, rural Newfoundland and Labrador, and somebody comes to your ER, you've not done endoscopy, nothing. The patient is vomiting like constantly and there's blood. Definitely, you're going to start the patient on IV proton pump inhibitor. You're not going to start the patient on um, antiemetic and just observe. That's not right. And if this was a CDM and you choose A, even if you chose C as well, that would be 0 because you are going to delay the care of the patient with that observation move, right? B, oral PPI therapy can be given after endoscopy, but IV PPI therapy is recommended initially for more rapid action. And secondly, the patient has ongoing vomiting. So oral PPI will not be the best, right? We've already said immediate endoscopy may not be appropriate without stabilizing the patient first. So you give your PPI, you give your IV fluids. That was what Dr. Sadaf was talking about when she was reviewing the first one. She snuck that in nicely, right? And then transarterial embolization is reserved for cases where endoscopic therapy fails. So you see, why did we reject A? Because it is a dangerous move to observe. Why did we reject B?
The patient is vomiting.
High dose oral patient is having ongoing vomiting, and the protocol is that patient with upper GI bleed start IV uh, proton pump inhibitor, as part of your initial management. If there was something about give IV fluids, I would have gone for that even before I give my IV PPI, right? But that one was not part of my answers. So then I'll go for that, which will stabilize the area of the bleed, and then we move on from there. And schedule immediate endoscopic therapy. We've learned that yes, we will do endoscopy, but this patient is hemodynamically unstable. So we want to
But
give
Dr.
some proton pump
Question
inhibitors.
already
We want to give some
scheduled.
fluids before we get the patient to the endoscopy table and perform transarterial embolization. That is above my pay grade. That's above my pay grade. I'm not going to do that. Okay, next question, doctors.
A 61-year-old male with a history of alcohol abuse present to the hospital after vomiting several times over the past 24 hours.
Oh my goodness, the way you are reading is so nice. Okay, continue.
Thank you. Thank you, Dr. Broni. He now has hematemesis and mild epigastric discomfort. Endoscopy reveals a small adherent clot at the gastroesophageal junction. What is the most appropriate next step in management? A, epinephrine injection only. B, endoscopic clip placement. C, start high-dose oral PPI and discharge. D, thermocoagulation. E, surgery.
Start high dose oral PPI and discharge.
Because nothing was mentioned about the hemodynamic status of this patient, and we need to go through the first line first before moving to other invasive. Endoscopic clip placement, nothing in the question indicate that the bleeding is uncontrollable.
Like, I like the way you were reasoning. The only thing is you were not privy to this specific information, like indication for endoscopic clip placement. You were not privy to that.
I went with the first principle we mentioned in the previous question, that we need to start with PPI first. And
sure,
I'm also.
No, that is true. But remember that you also said something that this patient is like they didn't talk about the hemodynamic stability of the patient. So it looks like you're not going to assume that the patient is not hemodynamically unstable. But then you are told that there is a clot adherence to the area, even though it is likely that clot may help with healing, right? But then, as you also study, you realize that there is an indication for endoscopic clip placement. And that indication is when you notice that there's a recent hemorrhage and there's a stigmata for that. And one of those stigmata is adherent clot at the area of the bleed.
Okay.
Yeah. Dr. Michael, please, your question.
Yes, please, sir. Can we go back to the previous question? That's question 1. Yes, sir. So this patient, 52 years, and here we are starting high-dose IV PPI therapy, right? So what's most likely the etiology of this upper GI bleeding in this patient?
No, because in clinical practice, even in our pre-printed order, so far as the patient has come, patient has upper GI bleed. It could even be variceal bleed. We don't know what the patient may have stigmata of liver disease and everything. IV proton pump inhibitor is one of the medications you give. Even the patient has stigmata of chronic liver disease, you know that this patient may have a malarialized tear, not malarialized tear, esophageal variceal bleed, right?
Yes.
Even if you are going to even give octreotide or whatever, or you put in your balloon tamponade, whatever, you still give IV PPI.
Okay.
It's part of the protocol.
Dr. Broni, I have a question.
Yes. Please ask your question.
We learned that in malarialized tear, healing occurs between 24 to 48 hours on most occasions.
Yes.
That was why the first question that we had, the PPI was wrong. So to give it, PPI was wrong. Observation was the correct option.
Yes.
So what is making us pick
the
PPI
fact that
instead?
there is still a clot attached to the area. Remember that the very first case we did, which we said we're not going to give anything, we're just going to observe. It said it had healed, like it had closed, and there was no active bleeding. This one, even though there's no active bleeding, there's a blood clot there, and that blood clot can come off. That is why you want to seal it so that the patient does not bleed again.
Okay, so if there is a chance of rebleeding, then it's when the PPI comes in. So
the PPI comes in, and then an added layer of treatment like endoscopic clot placement is placed. In fact, we'll be dealing with this when the class is about to end, and you will see what are the risk factors for rebleeding from malarialized.
Oh, okay. Thank you.
Beautiful. So now let's take it again. I want someone, based on all the confusion we've gone through, to take them one by one and talk through them. Remember that I gave you one question, which I said that the patient is no longer bleeding, and the endoscopy did not reveal any clot attached. The patient was hemodynamically stable. That patient, what did we do? We just observed. Do you remember that?
Yes,
remember?
Yes, we observed.
Number 2, that patient who was having active bleeding and was hemodynamically unstable, I said that we would make sure that we manage the patient's airway, breathing, and circulation. We give some fluids to bring up the patient's blood pressure. We'll even request blood transfusion, like we'll request grouping and cross-matching, right? Just in case the patient is becoming exsanguinated. And we'll give IV proton pump inhibitor.
Yes.
This particular patient, what were our answers? A, epinephrine injection. B, endoscopic plate placement. C, start high dose oral PPI and discharge. D, thermal coagulation. E, this patient, we did the endoscopy. We saw that there's a blood clot to the area. What we're going to do, determining the patient is hemodynamically stable, which the question didn't tell us, so we are not going to assume that the patient is not hemodynamically stable. Number 2, this patient will also receive IV proton pump inhibitor. But the answers did not give us that option, right? And then number 3, what is the next best thing we will do? Are we going to just give oral PPI and discharge home? No, that is dangerous. This
Mhm.
patient, I will put an endoscopic clip, maybe keep in the hospital for a day or two before I let the patient go.
Mm.
Mhm.
Yes, and endoscopy is
Yes.
also therapeutic and diagnostic. So it's
Yeah,
like
because as you are doing the endoscopy, as soon as
you're
you
also
get to the
clipping.
place, you can add your clip and then just seal the place and then come out. Right?
Yes, yes.
So what are the answers? Epinephrine alone is insufficient, as it increases the risk of rebleeding if not followed by another hemostatic measure. So you realize that you give endoscopy, you give epinephrine. Why? To reduce excessive blood flow to the area. But you don't just give epinephrine and go. Most of the time, after you give epinephrine, you may still want to put your clip, right? Number two, oral PPI can be started later, but immediate intervention is needed given the stigmata of hemorrhage. Number three, why is thermal coagulation not the answer? It may be considered, but it poses a risk of perforation. Remember, you are using heat, right? Unless you don't have the endoscopic clip. And why is surgery not the appropriate answer in this guy? Surgery is reserved for cases where endoscopic and angiographic therapy fail. So surgery is your last resort. If all the doctors agree, type yes. Let's move on. So you see the way we've just taken our time to break it down one by one by one. What do you do in this case? This particular patient, remember that the question did not even tell us that the patient has received IV PPI or not. But in reality, this patient will receive something like that. But the question is not focusing on that, right? Okay, next question, please. Let's go. Let's go.
A 43-year-old woman presents with a one-day history of vomiting and bright red blood in her vomit. Blood pressure is 120 over 80 millimeters of mercury and her heart rate is 95 beats per minute. Endoscopy reveals a superficial mucosa tear at the gastroesophageal junction with no active bleeding. What is the most appropriate management? A, observation and reassurance. B, start oral PPI for 2 weeks. C, epinephrine injection. And D, endoscopic clip management. Then the last option is surgery. So she has a superficial mucosa tear at the gastroesophageal junction with no active bleeding. So we just want to observe and reassure.
So in a stable patient with malarialized airway and no active bleeding, acid suppression with oral PPI is appropriate to promote mucosal healing. Okay. Observation alone is not sufficient. Acid suppression is necessary to stabilize the clot and promote healing. Because remember that when you look, they said there's still a tear. There's still a tear. It hasn't healed.
Okay.
Epinephrine injection, we learned that is unnecessary because if there is no active bleeding, why are you causing decreased blood flow to the area? And we also learned that epinephrine injection alone is not sufficient. And then we learned that endoscopic clips are reserved for patients with active bleeding or stigmata of recent hemorrhage. And what is that stigmata of recent hemorrhage?
Adherent clot.
Adherent clot. And what is the indication for surgery? When all other
Options fail.
plans fail, we go for surgery.